Imagine you're a nurse in a really busy emergency room. You have this critically ill patient, and you reach for your tablet to check their life-saving medication dosage, and the screen is just black,
Wow. Yeah.
completely locked. A hacker is demanding a ransom, and suddenly, you are basically practicing medicine in the dark ages.
It's terrifying, honestly.
It really is. Welcome to Tech Talks with Kinsoft. I'm so glad you're joining us at the table today. We are looking at the massive ransomware attack that hit the University of Mississippi Medical Center, or UMMC.
Right, which was just a massive event.
Huge. This intrusion was detected on Thursday, February 19th, 2026. And for this episode, we are drawing from detailed reporting from NPR, alongside some official statements from UMMC leadership and also public briefings from the FBI.
Yeah, and we really want you to understand why this matters. I mean,
Yeah.
This isn't just an abstract IT problem where, someone can't print a PDF. It's a direct, literal threat to patient care. It really showcases just the sheer vulnerability of the digital systems that we rely on every single day to keep people alive.
Yeah, our mission today isn't just to look at the timeline of a hack. We really want to understand the cascading failures that happen when a modern hospital's digital heartbeat just abruptly stops. So, okay, let's unpack this.
Let's do it.
We know the attack hit on February 19th, but it didn't just slow down a few administrative computers in the billing department. It completely paralyzed their Epic electronic medical record system, the EMR.
Which is catastrophic.
Right. And for those outside of healthcare listening right now, how fundamental is the EMR to keeping a modern hospital running?
Oh, it's the absolute central nervous system of the entire operation. I mean, an EMR isn't just, a digital filing cabinet where doctors type up their notes at the end of a shift.
It's way more active than that.
Way more. It is a highly integrated, totally automated ecosystem. So when a doctor inputs a command into a tablet, that system, it pings the pharmacy database immediately.
Right.
It cross-references the patient's real-time vitals on a completely separate server. And it can even automatically calibrate the IV drip that's physically attached to the patient's arm.
Oh, wow. So it's actually controlling the hardware.
Exactly. It manages the scheduling, the supply chain, the lab results, billing, everything.
Yeah.
If you sever that digital nervous system, the physical hospital just immediately loses its ability to coordinate.
That makes sense. So imagine a modern hospital without its electronic medical records. It's like a commercial airliner suddenly forced to fly with zero instruments, just completely blind in the clouds.
That's a really good way to put it.
Yeah, the engines are still running, the pilots are still in the seats, the passengers are all there, but you have no altitude reading, right? No radar and zero communication with the control tower. You are just flying blind and hoping you don't hit a mountain.
And hoping is not a great medical strategy.
No, definitely not. And from what the sources show, UMMC realized they were flying blind almost immediately. So, out of an abundance of caution, hospital officials made the deliberate choice to take all of their systems offline. They pulled the plug themselves.
They did?
But wait, if they pull the plug on the servers, aren't they basically just doing the hacker's job for them, shutting everything down?
It definitely seems counterintuitive, I'll give you that.
Yeah.
But it is standard incident response.
Yeah.
Because, ransomware doesn't just hit one computer and stay there.
It spreads.
Exactly. It relies on a mechanism called lateral movement. Once the malware breaches the perimeter, it basically crawls through the internal network, looking for attached servers, backup drives, any connected medical devices. It wants to encrypt as much data as humanly possible.
So it's like a virus in the body just hunting for new cells to infect.
Right. So by deliberately taking the systems offline and, severing the internal network connections, the IT team builds a firewall. They are actively trying to trap the malware in whatever segment it currently occupies.
Oh, I see.
Yeah, that way they can test and confirm the safety of the rest of the systems before the infection spreads any further.
Which isolates the problem, sure, but it creates a massive secondary crisis. You are basically inducing a coma to save the patient.
Yeah, and what's fascinating here is the specific language they used to describe that exact action.
What did they say?
Well, the UMMC Vice Chancellor for Health Affairs, Luann Woodward, gave a statement where she literally said, to use a medical phrase, we have stopped the bleeding.
Man, that is a very apt crossover between medical triage and cybersecurity.
It really is.
But let's look at the actual mechanism of that analogy for a second. A tourniquet stops a patient from bleeding out, but if you leave it on too long, you starve the limb of oxygen and you risk losing the leg entirely.
Yep, tissue death.
Right. So in this case, isolating the network stopped the malicious bleeding, the lateral movement of the malware. But it simultaneously starved the hospital of the operational data it needed to actually function.
Completely. And Woodward even admitted that 24 hours into the event, the full extent and scope of the intrusion was still not fully understood.
And that uncertainty has to be the hardest part. You apply the digital tourniquet, but you have absolutely no idea how deep the wound actually goes, or, how long you're going to have to keep the blood flow restricted.
Exactly. You're just waiting and hoping.
So they pull the plug on the servers to save the data. But the second those screens go black, the clinical floor is suddenly paralyzed. How do they actually treat the patients sitting right in front of them?
It's a huge scramble.
According to the NPR report, UMMC's main hospitals and their emergency departments, they did manage to stay operational. But the collateral damage was just immense.
It's statewide, too.
Yeah, they completely halted care at almost all of their 35 clinics statewide. We are talking about outpatient surgeries, elective procedures, imaging like MRIs and CT scans, all completely canceled.
That's wiped from the schedule.
They even had to cancel chemotherapy appointments. Which, I understand delaying an elective knee surgery, but why completely halt something as critical as chemotherapy?
Well, it's because modern chemotherapy is not just some simple static process. It relies so heavily on precision digital dosing.
What does that mean exactly?
So a patient's required dosage can fluctuate wildly just based on their daily blood work and vital signs. In a fully functioning hospital, an algorithm analyzes those daily lab results and calculates the precise, safe mixture of these highly toxic chemicals.
It's basically poison, right? You're trying to kill the cancer without killing the patient.
Exactly. So if the EMR is down, the pharmacy doesn't have immediate access to those shifting lab results. And worse, the automated safeguards that flag a dangerous dosage miscalculation, those are gone.
Oh, wow.
Yeah, administering complex chemotherapy totally blind is just simply too risky. The liability and the danger to the patient is too high.
That makes a lot of sense, but it just highlights a brutal reality. The system isolation forces these administrators into making impossible triage decisions. However, looking at the sources, there was one vital operational exception that really stands out.
The dialysis clinics.
Yes. While almost all of the 35 clinics were shut down, the kidney dialysis clinics remained open. Why did dialysis make the cut when chemotherapy didn't?
It really comes down to the immediate biological mechanics of the two treatments. If you delay a chemo session by a few days, it's incredibly stressful.
Right, and detrimental to the long-term plan.
Yes, but the patient is unlikely to experience a fatal crisis that specific afternoon. Dialysis is fundamentally different. The patient's kidneys have failed. Their blood is being artificially filtered by a machine.
So there's no natural backup system in their body at all?
None. If you skip a critical dialysis appointment, toxic waste products and excess fluid build up in the bloodstream incredibly rapidly.
Like within hours?
Within a matter of hours or maybe days, yeah. That buildup can trigger cardiac arrest or severe pulmonary edema. So UMMC had to draw a hard line based on immediate acute mortality risks and say, no matter what, we have to keep this specific service running even in a total system blackout.
Which brings up the logistical nightmare of the emergency rooms and the ongoing care that didn't get canceled. The sources noted that staff had to revert to pen and paper downtime procedures.
The dreaded downtime procedures.
Right. Now, I hear pen and paper, and I picture like an old school doctor with a clipboard. Sounds kind of quaint, but what is the actual operational bottleneck here? Why does writing things down cause such a massive failure in a modern hospital?
The bottleneck is just the physical speed of information transfer.
Okay.
In a digital environment, the friction of communication is practically zero.
It's instant.
Right. A doctor orders a medication, and the software instantly cross-references the patient's chart for allergies. It checks for negative interactions with other drugs. It then immediately pings the pharmacy. The pharmacist fills it, scans a barcode, and the nurse scans the patient's wristband to verify the match before giving the drug.
And that whole process takes, what, a few seconds?
The entire validation process takes seconds, yeah.
But on paper, you lose all of those automated safety nets.
Entirely. A doctor handwrites the order. Someone physically has to walk that piece of paper down to the pharmacy, which might be on a completely different floor or even a different wing of the building.
Just burning time.
Right. And then the pharmacist has to manually check massive physical reference books to ensure there are no drug interactions. And here is the truly dangerous part.
Okay.
Because the digital patient history is locked, the pharmacist is relying purely on the patient's memory of what they are allergic to.
Oh, man. And if the patient is unconscious or confused or simply doesn't remember the exact name of their blood pressure medication, you are basically rolling the dice.
Exactly.
Not to mention the classic medical trope of misreading handwriting. If a nurse misreads a hastily written 10 milligrams as 100 milligrams and the safety software isn't there to throw a red flag, I mean, that is a catastrophic human error.
It happens so easily, too.
You are taking a high-speed precision operation and forcing it to run on a physical infrastructure that simply doesn't exist anymore. Hospitals today aren't built with the pneumatic tube systems or the massive clerical staffing levels they had back in 1990 to support paper charting.
Exactly. The architecture of a modern hospital is designed for data packets, not paper flow. So when you force a 2026 medical staff to use 1990s workflows in a building optimized for Wi-Fi, everything just slows to an absolute crawl.
And dealing with these paper records and this sort of slow-motion medicine was only ever meant to be a temporary failsafe. But the duration of this specific outage was brutal.
9 days.
Yeah, the clinics stayed closed for roughly 9 days, finally reopening around March 2, 2026. In the tech world, a 9-day server outage is a major headache. But in a statewide healthcare network, 9 days of canceled surgeries and delayed diagnoses is a massive public health event.
It's a disaster.
They obviously had to bring in outside help to deal with the root cause, which shifts our focus to the investigation and the recovery phase.
Yeah, UMMC definitely didn't try to handle this in isolation. They worked directly with federal authorities, specifically CISA, the Cybersecurity and Infrastructure Security Agency, and the FBI.
Bringing in the heavy hitters.
Oh, yeah. The FBI special agent in charge of the Jackson, Mississippi field office, Robert Eichhoff, was actually quoted in the reporting. He noted that the Bureau was surging resources, both locally and nationally, to restore patient care.
Let's translate that phrase, surging resources. What does that practically look like when the FBI gets involved in a hospital hack? I imagine they aren't just sending a couple of agents in suits to look at servers, right?
Oh, far from it. When the FBI surges resources into a cyber incident like this, they are deploying specialized cyber action teams.
Cyber action teams?
Yeah. These are highly trained units that include forensic analysts, malware reverse engineers, and network defense specialists. Their first priority, as Eichhoff stated, is assisting the medical center in getting systems back online safely. But simultaneously, they are actively hunting for the attackers.
And how do they actually do that? Like, when the sources say the FBI is analyzing a malware signature, are we talking about the digital fingerprint of the code? How does the FBI use that to figure out which hacker group is responsible?
A malware signature is exactly that. It's a unique digital fingerprint. Because ransomware code isn't usually built from scratch for every single attack.
They reuse code.
Yeah, hacker syndicates reuse specific blocks of code, specific encryption algorithms, and even specific communication protocols. So the FBI's analysts will isolate the malware found on UMMC servers and compare its signature against a global database of known cyber threats.
Oh, that makes sense.
If the code matches the signature of a known ransomware gang, the FBI suddenly knows a lot about their adversary. They know the gang's typical negotiation tactics, what vulnerabilities they usually exploit to gain entry, and most importantly, if there's an existing known flaw in their encryption that can be used to unlock the data without paying.
It's like trying to find the master key to a hotel where the locks change every 5 seconds.
Very much so.
But here's where it gets really interesting, though. Woodward, the vice chancellor, confirmed at a press conference that hospital officials had actually communicated with the attackers.
Yeah, they did.
Hold on a second. Law enforcement usually operates on a strict policy of, we don't negotiate with extortionists. Why on earth would a hospital open a back channel with the very people who just paralyzed their entire operation? Doesn't that just invite further exploitation?
If we connect this to the bigger picture of ransomware economics, communicating with the attackers is a very deliberate, high-stakes tactical move. And, doesn't necessarily mean they're negotiating a payout.
So why do it?
There are a few core operational reasons to establish that communication, which is usually done via a secure, anonymous channel on the dark web. The most critical reason is demanding proof of life.
Proof of life? Like a kidnapping protocol. How does that work with digital files? I mean, how do you even verify a decryption key without accidentally triggering more malware and making the whole infection worse?
It's handled through a highly controlled technical process called sandboxing.
Sandboxing, okay.
Yeah. The hospital needs proof that the attackers actually possess a working decryption key and proof that the files aren't permanently corrupted. So the hospital's IT team, often working alongside those FBI specialists we talked about, will provide the attackers with a few encrypted low-value files.
So they basically test them.
Exactly. The attackers decrypt them and send them back. The IT team then opens those return files in a sandbox, which is a completely isolated virtual environment that has absolutely no connection to the broader network.
That's smart.
If the files open cleanly, they have verified the proof of life without risking further infection.
And I imagine opening that channel also buys the investigation time. Like every hour the hackers think a negotiation is happening or that the hospital is considering paying the ransom is an hour the FBI has to reverse engineer the malware or trace the server logs to find the entry point.
Precisely. It is essentially a stalling tactic. It gives the internal tech teams time to comb through their offline backups to see if they can rebuild the network from scratch without needing the attacker's key at all.
Wow. But looking at the sources we have from NPR and the official statements, it's really crucial to note what remains unconfirmed here.
Right, there's a lot we don't know.
Exactly. At the time these reports were published, the sources did not explicitly state whether a ransom was ultimately paid. Furthermore, the full scope of the intrusion was still under investigation. It was completely unclear if sensitive patient information like medical histories, social security numbers, or billing data had been officially stolen or exfiltrated out of the network before the encryption locked it down.
And that lack of confirmation represents the secondary trauma of a cyber attack.
What do you mean by secondary trauma?
Well, the primary trauma is the operational shutdown, right? The canceled surgeries and the 9 days of clinical paralysis. The secondary trauma is the long-tail privacy threat. Hackers often engage in double extortion.
They lock the systems A&D steal the data.
Exactly. They lock your systems to halt your operations, but they also steal the data and threaten to publish it online if you don't pay. For the patients of UMMC, the uncertainty of whether their most intimate health details were compromised is just an agonizing position to be in.
Yeah, I can't even imagine. So what does this all mean? We've looked at the timeline, the transition to paper workflows, the closure of 35 clinics, the dialysis exception, and the FBI surging resources to analyze malware signatures.
We've covered a lot.
We have. And if we pull all of these threads together, I think this discussion really highlights a fundamental shift in how we need to view technology. First, it exposes the absolute fragility of our healthcare infrastructure. We've built this incredible, highly efficient system that can deliver life-saving care with pinpoint accuracy, but we've built it on an API architecture that can be paralyzed by a single malicious intrusion.
It's a house of cards.
It really is. Second, it proves the absolute necessity of analog survival skills. A hospital's ability to revert to pen and paper isn't just, an administrative backup plan. It is a critical, life-saving operational requirement. And finally, it cements the reality that ransomware is no longer just a data privacy issue or a financial headache for corporate IT. It is a direct operational threat to human safety. It's literally a weapon that shuts down chemo wards and forces doctors to fly blind.
It forces a complete reevaluation of what constitutes critical infrastructure in the modern era. And it leaves me with a thought that I find genuinely concerning as we look toward the future. Well, we just spent a lot of time discussing the immense friction of reverting to paper charts, and how modern hospitals aren't architecturally designed for it. Yeah. But at least today, in 2026, there are still senior doctors and nurses on staff who remember the pre-digital days.
Right, people who trained on paper.
Exactly. They remember how to cross-reference physical pharmacy books and manage floor operations manually. As our medical tools, our AI diagnostics, and our robotic surgeries become even more advanced and entirely reliant on cloud architecture, what happens a decade from now?
Oh, man.
What happens when a hospital is hit by ransomware and returning to pen and paper is no longer practically possible because the new generation of medical professionals were never trained on analog systems to begin with?
That is a chilling thought. If the analog safety net rots away because we simply forgot how to use it, that is a vulnerability that no software patch or FBI cyber action team can ever fix.
No, they can't.
It's something every industry needs to be thinking about as we push further into this hyper-connected age. If today's discussion got you thinking about the vulnerabilities in your own network architecture, or if you are wondering how your own operational safety nets would hold up under pressure, don't wait for a crisis to find out where your blind spots are.
Like, safe than sorry?
Exactly. Visit www.kinsoft.com.au to discuss your security and IT needs. You really want to build and test those safety nets before you actually have to fall into them. Thank you so much for joining us at the table today for Tech Talks with Kinsoft, and we'll catch you on the next one.